Hello, I'm Dr. Richard Chanik, and I'm joined by my colleagues Dr. Vic Tapson and Dr. Rajan Sagar. And we're going to talk about a group of patients between pressures of 20 and 24 with pulmonary arterial hypertension. This group of patients previously was not considered as having pulmonary hypertension, but in the new definition from the World Symposium on Pulmonary Hypertension, those patients are now defined as PH patients. And so one of the questions that comes up then is how we assess these patients, what we do about them, whether we treat them or not, but what is the approach to reassessing these people who some would consider having mild pulmonary hypertension, but may or may not actually be mild. And so I want to get both of your feels on how you approach in your practice, how you assess, how you reassess, what kind of things you do to follow these patients that we're certainly all seeing. Maybe I'll start with you, Raj.
Yeah, obviously it's a new business for all of us to be looking at this milder phenotype, or at least in terms of pressures. But I think we have to emphasize that these patients have, albeit lower mean PA pressures of 21 to 24, but they still have pulmonary vascular resistances of greater than 3, greater or equal to 3 Wood units. So they actually do have PAH, and I think it's going to be a rare patient. But having said that, I think the key, at least in my practice, is going to be trying to objectively determine their baseline function and trying to understand what we're trying to improve. So I'm assuming these patients have some sort of dyspnea on exertion, some symptom that brings them to your clinic. As we all know, objectifying the follow-up is critical. And I think especially in this population, because we're all going to be stuck with the key question at 3 months on therapy, if you choose to use therapy, should I continue this therapy? So I think I'm going to focus on, if I choose to actually treat one of these patients based on the other data available to me, to try to objectify that as much as possible. And what comes to mind is, more than just 6-minute walks and patient conversations and talking about symptoms, is using cardiopulmonary exercise testing as a baseline study perhaps, or even considering a cardiac MRI in a patient like that, but just trying to have something that I can follow up in the near future.
And Vic, what should be the schedule of follow-up?
That's a great point. I like the term structured follow-up. We were in a meeting earlier today. My colleague Sean Studer was talking about this. He likes the term structured follow-up, but it doesn't mean see someone back in clinic. It means see them and do something in an organized fashion like Raj alluded to. So to me, it would always be obviously detailed H&P, BNP, 6-minute walk at the clinic visit. I wouldn't do an echo necessarily every visit, but I want an echo probably in someone like that with a mean PA pressure between 20 and 24 at cath. Probably an echo every 6 months for a couple of visits. But again, I think the structure is key, and making sure you have an organized manner of doing this. I like the idea of CPET. At our center, we don't routinely CPET patients. There's a diagnostic dilemma. Some do, it may be valuable, but this is a particular population where I think doing exercise testing maybe more than once, maybe on a structured sort of follow-up basis might be useful.
Yeah, because even if you're not treating these patients, it's very important to follow to make sure they're not progressing. And this has been studied to some degree, the progression of these patients in that so-called mild range, what happens to them over time. Do we have good data? Do we need more data on this?
We certainly need more data. We certainly need prospective randomized data, but we do have some data, Rich. As you know, in high, obviously the theory is that if you have, PAH in this range of mean PA pressures, that initially our hypothesis in high-risk populations such as scleroderma was that if you had a mean PA pressure between 21 and 24, without any discussion of PVR, and that needs to be kept in mind, that if you actually exercise these patients, they would and often did have abnormal exercise responses. And the thought was, well, if we treat these patients early, perhaps we could alter their natural history in terms of eventually developing resting PAH, 25 or greater, and a PVR greater than 3. The Kovacs group and the Austrians looked at this very nicely and had published their 5-year follow-up in this population to look at this natural history. And actually, I think we were all surprised to see in some way that a lot of these patients, most of them in fact, do not progress starting with mean PA pressures of 21 to 24, again, without PVR as a consideration.
Yeah, I agree as a population, but let's just bring it to the practice. Have you seen, we've all followed these patients. have you seen any of them really sort of, quote, fall off the cliff? And I mean, I feel like I have from time to time. I agree it's not common and maybe it's a stable group, but I mean, have you seen any that really are, I guess, the exception that really do progress?
Yeah, I think we see these now and then, Rich. It's pretty rare, though. I think everyone with PAH, everyone with PH, has a mean PA pressure between 20 and 24 at some point. They have to, if they're, progressing. It starts off normal. Say what's normal. Stop.
Well, I guess that's it. Actually, let me, I guess maybe push back a little bit on that. And is that really true? Do we know that, or are there patients who are just severe from day one?
I think to me,
and is this? I guess the fundamental question is this early disease or mild disease?
I think the question is, and I think to me it seems imperative. There's got to be a continuum. You've got to have a mean PA pressure. Normal, say it's 14. It's got to be 17 before it's 20, and 20 before it's 25. And so we used to call we have patients with exercise-induced PH that maybe never progress. Some of those patients actually do progress, and they're patients on their way to full-blown resting pulmonary hypertension. Yeah. So I think I don't think we're going to see a lot more of these patients, Rich, but I do think we got to think about them carefully, like has been suggested here. And there's other groups. There's COPD, right. IPF. We've seen in those patient groups, actually, if your PA pressure, granted they're different, their PA pressure is under 25, they still progress and have a higher mortality than someone who doesn't have that degree of PH.
That's a great point. I mean, Raj, you've published on ILD and pulmonary hypertension, and that's a fair point. We haven't talked about those patients in that 20 to 24 range. Are they different?
Yeah, it's a really great question. Again, I think we're talking about populations that get screened more heavily, for instance, as opposed to sort of PAH. Just going back to our original discussion here, I would argue that my own sort of gestalt is that this mean PA pressure between 21 and 24 is a little bit of a different disease. I don't want to say sort of how we see like calcium channel blocker patients respond differently, and
phenotype.
It's a phenotype that may be quite different than what we're seeing. And just going back to your point, I actually do feel like a lot of these patients who develop severe pulmonary hypertension, it's rather an abrupt change in their status. A lot of our patients will tell us that they were fine and doing their activities as usual 3 months prior to their significant change in status.
Yeah, and as we identify more and more of these patients now with this new definition, we'll have an opportunity to really follow these patients and get a lot more data about natural history. So that's all the time we have for this segment. Thank you very much. Thank you.